Hello, and thank you for joining us for this lecture on lumbosacral anatomy, biomechanics, and movement. In this lecture, we're going to be talking about the lumbar anatomy and biomechanics. We're going to be looking at different aspects of the lumbar vertebrae and also facet orientation. And then we're really going to delve into movement and biomechanics of both the lumbar spine and the sacrum. And what's tricky about this is that we can look at this as either sacroiliac motion or iliosacral motion. So how does the ilium move on the sacrum, and then how does the sacrum move on the ilium? I guess the bigger question behind both of those is how clinically significant is that? And personally, I don't think it's nearly as clinically significant, but if you can understand the movements, then you can relate it to your patients much easier. First, we're going to start with the lumbar spine and a brief overview. First, 80% of people will report low back pain at some point. That means 4 out of 5 individuals are going to have low back pain. And of those 4, 33% are going to have a recurrent episode of pain. So they have back pain, and then their chances of having a recurrent episodes or a second or third episode is 1 in 3 people. And that's pretty significant. Also, over $86 billion are spent on spinal issues each year, and the only thing that trumps that is cardiovascular disease and strokes. And so that's pretty significant as well. It's that we are spending a significant amount of healthcare dollars on spinal issues, and I believe physical therapy and other musculoskeletal specialists should be at the forefront of treating spinal issues, especially low back pain. Fortunately, less than 5% of the population develop persistent pain, which means they become somewhat disabled by their low back pain. But what's sad is that historically, thus far, no interventions, even those provided by a physical therapist, have been shown to have widespread effectiveness for people that meet this low back pain and disability category. And that came from the OCS Current Concepts of the Lumbar Spine, the 4th edition. But it's just amazing that we have all this research. We're spending billions of dollars each year, yet we have no interventions that are showing widespread or very beneficial effectiveness for people that have chronic low back pain. And I think part of that reason is that we have to reframe how we view anatomy and then also how we look at pain. Imaging is often going to show degenerative disc changes. It could show osteoarthritic changes, potentially some even nerve compression at different areas. But we can't say that dysfunctional anatomy causes pain. It was Waddell who said, it's disturbed physiology, not disturbed anatomy, that causes back pain. And that's so true, that we need to be educating our clients that anatomy does not equal pain. When looking at the lumbar anatomy, this is a typical lumbar vertebrae, and we're looking at it from the superior view. So you can see the very large box-shaped body. In addition, you can see the location of the pedicle over on the right-hand side. So you have 2 pedicles that create the space for the vertebral foramen, and that is where the spinal cord goes down through, which becomes the cauda equina at the L1-2 level. Also in this picture, you can see the superior process, or the superior articular process, which makes up half of the facet joint. So you have your superior articular process, which meets the inferior articular process of the superior vertebrae. So those things come together, and that's what makes up your facet joints. Just inside of that, towards your spinous process, you can see the lamina, and then the very large spinous process, which is important for muscle attachment. And then also the term pars interarticularis. And what that is on a single vertebrae, so if you take this lumbar vertebrae and turn it 90 degrees to the left, you would have your superior, here's your vertebral body, your superior articular pillar, inferior articular pillar, and that space right between the two is the pars interarticularis, or where a spondyloliphysis would occur. Lumbar discs are a very popular topic to discuss because so many people have disc degeneration. And as you'll see on the next slide, lumbar disc degeneration is a common cause of lumbar just osteoarthritic changes. But it is so common that we kind of view them as internal gray hairs, where almost everyone is going to have disc degeneration. Just as we age externally, you can see wrinkles on the skin as someone gets older. We also age internally, and the discs are a common sign of that. When we talk about disc anatomy, you have two primary layers, your outer annulus fibrosus, and then the more inner nucleus pulposus. And you can see those two layers in the picture on the superior view on the right. The annulus fibrosus is composed of concentric layers of fibrocartilage. And these layers, which we don't have a good picture of here, but they crisscross each other, and that forms a very strong structure for the disc. Now, it still allows for motion and shock absorption, but it creates a stiff structure that allows for good shock absorption and movement. The inner nucleus pulposus is that more kind of gelatinous central mass. And when we think about a disc herniation, many people think of more of that gelatinous center area. The discs also have innervation, or they're innervated in themselves, and that is from the sinovertebral nerve. The function of the disc is to help with shock absorption and then also resist tensile forces in nearly all directions. So when you extend backwards to reach for something or bend forward, they help resist tensile forces and keep space between the vertebrae. I think it was McGill who said that flexion and rotation places the most amount of stress on the disc. So that movement, especially in someone who has an acute disc herniation, would likely be pain-provoking. But because they provide shock absorption and because they're spacers for the vertebrae, they allow for spinal motion. So they're very important structures. And as I mentioned before, their natural degeneration occurs with the aging process. They've done studies that have looked at people from 25 to 65 years old. And what they found is that as you get old, even people in their mid-20s and 30s already have degenerative changes. And then that incidence and prevalence significantly increases when people are 55, 60, 65 years old. Lumbar ligaments. So I put two different pictures up there. And as you can tell, the one on the top is clearly the cervical spine. And just to orient you, on the far left of that top picture is where the anterior longitudinal ligament runs. And the reason I wanted to show you both of these pictures is because these structures run all the way up on the cervical spine, down through the lumbar spine to the sacrum. The anterior longitudinal ligament, as you can see in both of those pictures on the left-hand side, is on the front surface of your vertebral body. So if here's your vertebrae, here's anterior, it runs all the way along the front surface. And as you can imagine, it resists extension of the spine. So if it's anterior to it, extending back is going to make that more taut and limit that movement. Just on the back side of the vertebral body, so we're still in front of the spinal cord, is where the posterior longitudinal ligament is. So you have anterior in front of the vertebral body right here. Just behind that is the posterior longitudinal ligament, and it helps resist lumbar or whole spinal flexion. So hyperflexion is what the posterior longitudinal ligament resists. Next, we have our interspinous and supraspinous ligaments. You can see in the picture on the far right of the bottom picture, there is the supraspinous ligament, and then also the interspinous ligament. Now, these, from a functional standpoint, especially clinically, probably have minimal clinical significance, but they're thought to be rich with proprioceptors and likely other either nociceptors, but they don't they don't resist a ton of motion through spinal movement. The ligamentum flavum, which you can see in this picture as well, just in front of the interspinal ligament, is going to, it's also known as your yellow ligament. And the reason that is that it's highly elastic. And that's important. So when someone bends forward, it allows that person to naturally come back up into an upright posture. So it's important for upright posturing. But let's say someone extends all the way back. Well, the elastic portion is very crucial here, because if that ligament wasn't elastic, it would simply buckle down, and the elastic portion allows it to, almost like a rubber band, go back and forth without buckling on itself, which could cause spinal cord impingement. Finally, the iliolumbar ligament, which we will talk more about in the SI section. So the facet joints. These are, as I talked about earlier, you have from every superior and inferior vertebrae, those match, and this allows for the normal arthrokinematic movement. These are true synovial joints. So there's a joint capsule that surrounds these, and it's lubricated by synovium. So they typically have that nice synovial layer, allows for minimizing friction and allows for smooth motion. Conditions such as osteoarthritis can contribute to limited mobility. So with osteoarthritis, we have some cartilage breakdown and connective tissue breakdown, which does not allow for that normal synovial fluid exchange. And that's why the facet joints, if we have OA in the facet joints, people are often going to complain of stiffness, pain, decreased range of motion. Next, the lumbar nerves. These can be a tricky topic for many people, and what you see in the picture here is our lumbar plexus, and that is the T12 to L5 nerve roots, but this works closely with the sacral plexus. So if you think about the anatomy of the sciatic nerve, it goes from L4 to S3, so it comprises both that lumbosacral plexus. As I mentioned earlier, the spinal cord ends at the level of L1-2, and then after that, it becomes this cauda equina, also known as the horse's tail. And that's important because if someone would have a severe laceration of the spinal cord below that level, it would have different effects than if it was the spinal cord above. These lumbar nerves, as you can see here, they supply both sensory and motor innervation to the thigh and lower leg. So these nerves are very important for function of the lower extremity. Some of those important nerves are going to be your femoral nerve, and then also the different branches of the femoral nerves, your lateral femoral cutaneous, your saphenous nerve. More on the anterior portion, we have our obturator nerve, which feeds the adductor muscles and also provides sensation to the inner thigh. And then also branches of the perineal nerves. And so as the sciatic nerve, it branches from your lumbosacral plexus, comes down and turns into your tibial and common perineal nerve. And those eventually have further branches into the tibial and digital nerves. So the lumbar nerves are very important. A classic compression injury example would be someone who comes in and they, let's say, have a compression type injury from poor lifting mechanics. And the anatomical correlation could be an acute disc herniation. So we have someone who presents with lumbar nerve root signs and symptoms, which means that they're having dermatomal weakness, myotomal weakness, they're having hyporeflexia, and then also symptoms that they're going to present with are they're going to be unable to bend forward, or flexion will likely increase symptoms down their leg. And so that is when someone has symptoms going down their leg, it's likely going to be either a nerve root compression, maybe central spinal cord compression, or it could be a peripheral nerve issue, or a combination of multiple ones there. The treatment, which Chris gets into later, is finding a directional preference, unloading the joint potentially, so maybe potentially traction, which hasn't shown the best, but maybe traction with some walking at the same time would be great if you have an unloader. Manual therapy, definitely. And then prolonged exercise at low resistance. So that could be doing a bike, doing the total gym, but very low load, repetitious movement, because the nerves need a lot of oxygen. So getting blood flow to that region following an injury is going to be crucial. Since we mentioned the nerve root compression, we talked about dermatomes and then also myotomes. And myotomes of the lower extremity would be from L2 to 3 is your hip flexors, L3-4 is knee extensors, so your quad, L4-5 is your ankle dorsiflexion, L5 is great toe extension. And so if someone comes in with lumbar nerve signs and symptoms, you definitely want to be checking the myotomes, because this is a quick assessment of just gross motor function. And so say someone can't raise their great toe, it's a sign that the L5 nerve root is likely being compromised. L5 nerve or potentially the peripheral nerve distally somewhere. So that's just a quick clarification. With lumbar muscles, I didn't put a ton of pictures up here because we're going to talk a little bit about this in the SI section. But in general, these help produce and control trunk movements. They control the trunk for upper and lower extremity movement too. So the trunk needs to be stable while the arms raise overhead, for example. A common cause of low back pain is the inability to brace or keep the core in a neutral position while the arms and legs are moving. You might see this in someone who, as they're trying to run, their hips sway from side to side. So the core muscles are not activating appropriately, and you're having more stress, causing less efficient movement of either the upper or lower extremity. When we talk about specific muscles, the erector spinae are the primary extensors of the spine. The multifidi help resist lumbar rotation, and then also do provide some function for extension. When you think about your classic core model of the 4 core muscles, we have your TA or transversus abdominis in the front. On the posterior side of that is going to be those multifidi. So they're very important. They're highly innervated and also have a lot of proprioception in the multifidi. But those muscles really do help provide this core deeper stabilization. Also, the psoas and rectus abdominis assist with trunk flexion. That is important because a lot of people, I would say, overuse their psoas and rectus abdominis, and that's kind of using the word dominant or non-dominant is controversial. But definitely people who have a difficult time activating their deeper core muscles, such as their transverse abdominis, they often overuse their psoas or their TFL, and then they also tend to engage from their outer rectus, where they aren't using an appropriate bracing strategy and trying to use muscles elsewhere. And then finally, the thoracodorsal fascia helps contribute to stability. And by engaging your transversus, it naturally takes up tension through the thoracodorsal fascia, but then also the thoracodorsal fascia is closely connected with your latissimus dorsi and your gluteal muscles. When we talk about biomechanics of the spine, there is about 60 degrees of flexion, 35 degrees of extension, 25 to 30 degrees each way of lateral flexion. And then with rotation, it's very difficult to assess. What we know is that there's not much lumbar rotation, and the majority of it should come through the thoracic spine. I will say that I look at some different criteria when measuring flexion and extension. Typically, I follow the SFMA criteria, which means that when someone bends forward, I'm looking to see where they're getting their movement from. I'm looking to see if they're having an adequate posterior translation from their hips. So while these lumbar ranges of motion degrees may be important if you're in physical therapy school or preparing for the OCS exam, clinically, I would really look for where the quality of movement, quality and quantity is coming from. Okay, arthrokinematics. These are, fortunately, in the lumbar spine, fairly simple. So when someone goes into lumbar flexion, the vertebrae are going to go up and forward relative to one another. So as someone flexes forward, you're going to see opening through the vertebrae. So flexion is going to be a more open position of the facets, but also of the spinal cord. And that's why you'll see someone who has spinal stenosis, they kind of prefer that position where they can rest their hands on their thighs, because being forward opens everything up. But what happens there is the vertebrae go up and forward with flexion. The opposite occurs with extension. So if someone extends back, it's going to be a down and back motion, and the vertebrae are relatively closing on each side there. With lumbar rotation and side bending, what you'll see is that if I would rotate to the right, it's going to be a relative closing on the right. So that'd be mimicking the same movement as extension. So on the right side, they're going down and back. But then on the left side, the vertebrae would be opening up. So it's going up and forward on the left, closing down and back on the right. And that's with the right rotation or right side bending. So think about, when you think about flexion, it's going to be similar to, let's say if I'm rotating on the right, contralateral, the same mechanics as what's happening on the contralateral side for side bending and rotation. If you have further questions about this, we break this down further in the cervical course, but I would just know that with flexion and extension, they're happening bilaterally, and then the opposite things are occurring with rotation and side bending. So here is a picture of someone that's going into forward flexion, and I also want to talk about the return from forward flexion. As I mentioned, normal degrees of motion would be about 57 degrees. And what I look for is when someone goes down, do they posteriorly weight shift? Are they keeping their knee straight? Do they get motion from all parts of their spine? And then also, does the TL junction move over? Does the TL junction end over the foot or end over the toes? So people often will have limited full forward flexion, and they'll also often have limited extension of the lumbar spine. One thing that I commonly see that causes people to have some low back pain or tension is as they return from forward flexion. So someone's all the way down, and then as they extend, instead of using their glutes as hip extensors, you'll see this quick and early lumbar extension, which causes the erector spinae to activate early, and it can cause some muscle spasms in the low back. So I would look at people when they go forward, but then also as they return from that movement. As that last bullet point says, symptoms should decrease when the patient extends their hips first and gradually extends their back. But you'll see that kind of early and active lumbar extension where they lock out their low back, and that can be a big cause of some low back tension. I have to clarify here that lumbar extension is very important. It's not a bad movement, but with these people, they constantly favor that extended lumbar position where they're overactivating their erector spinae and not using their glutes, and that over time feeds into kind of their pain response. So really watch how they bend forward and watch how they return. On this one, I have 3 different videos, and I know kind of the hinge point model. People often ask, do hinge points in the low back matter? I would say they really are not too significant, but they do give you a window into how that person moves. And so I talk a little bit about the hinge points here, but really look for total range of motion. And the picture on the far left is someone going into low back extension. And so you can see a little bit of a hinge point with that movement, but more importantly, as that person goes back, I'm looking to see how the hips translate forward. Are they getting movement through all parts of their spine, or are they just kind of falling back into the low back? So it's really a total quality of movement. In the second video, we have someone going into full rotation. And with full rotation, you should see the opposite shoulder peek out. So in this gentleman, the left, you can't quite see the left shoulder, but with rotation, it's going to be a combination of lumbar rotation, but then also the hips need to rotate here. It's very hard to tease out lumbar rotation because it's a small movement, and the hips and thoracic spine play such a huge role in lumbar rotation. And then finally, you can see this is me doing a right side bend. Now you can ask yourself, does that hinge point matter? Well, I would say, does it coincide with their symptoms? So at this time, I was having some right-sided low back tension, and it was really due to some improper lumbo-pelvic mechanics. So by correcting my hip mobility, by actually working on that right side bend range of motion, I have now pain-free right side bending. But just know what should happen in this situation as someone goes into right side bending, so overhead movement, the hip should shift to the left, and you should look for a nice curve of the entire spine. So you shouldn't see like a huge break point in the spine. Okay, so that was a quick overview of the lumbar spine. And next we're going to get into the sacroiliac joint and the biomechanics and anatomy of the SI joint. If I would pose the question of who here has difficulty treating sacroiliac joint problems, probably almost everyone would raise their hand. And that's because this region is so ambiguous. And what I find is that typically people with SI dysfunction have a true lumbar issue or a hip issue. So if you think that the SI joint is built for stability, so if something is supposed to be stable, well, usually something above or below is not doing its job. As you can see here, SI dysfunction, the prevalence is relatively low, but it does increase in hypermobile individuals. So it is possible in people who are very hypermobile, but then also it's possible in those who are pregnant, and those kind of go hand in hand. An interesting fact about the SI joint is that after middle age, the prevalence of SI joint issues significantly decreases. And that's because nearly 3/4 of people over the age of 50 have a fused SI joint. So naturally, based on the anatomical makeup of the joint, it fuses as people get older. So there really will be no movement there. So it's hard to say that that's a cause of pain later on in life. As that last bullet point says, many people question if the SI has movement and or if it can truly be a pain generator. I typically subscribe to that. Well, there is small amounts of movement in there when you're before middle age, especially, and I don't see why it could not be a pain generator. So it's a joint just like anything else. It just doesn't have very much movement. Here is a quick case study on someone who is having SI joint pain, but that actually I believe was coming from his low back and hip mobility also. But as you can see, the person who's having pain is on the left, and then that's me doing the same position on the right. And as this individual went into that posture, you can see how his hips and low back are not allowing normal force distribution through that SI region. So on me, there's a more of a natural low back curve, and on him, he's just offloading that area by shifting his body weight that way, and he's not properly loading through his left hip either. He came in with a complaint of left SI pain. He had that positive Fortin sign, and then also he has a congenitally fused L5-S1, and that's kind of pertinent because if that region's fused, it will decrease mobility. But you can see the clear differences side to side in how he's loading through his left side of his low back and then also into his left hip. So we worked on range of motion in his hip and his low back, and it significantly improved both pain and how that movement looks. A little bit on nomenclature. 1 second, the computer is low on battery. Next, if we talk about nomenclature, there are so many terms that are used throughout the research. So even when we talk about the biomechanics, I'm going to say, let's keep it simple, and you'll see why. Because you can say nutation, counter nutation, or is that flexion and extension? Is there torsions, upslips, anterior nominates? And what we have seen through the research is that with all of this, we have no consistency, and then it's so hard to diagnose these things, and then it really does not matter clinically. So my idea is we should drop this nomenclature, so get rid of all these terms, and then start simplifying things. When we talk about the SI region, there are 3 bones in the pelvis. So you have your left innominate, your right innominate, and then the sacrum in the middle. So those are the 3 bones of the pelvis, or of the sacroiliac joints. There's 3 joints here. So you have your left and right sacroiliac joints, where your left innominate meets your sacrum, and the same thing on the other side. And then also your pubic symphysis. So that is the joint as your pelvis wraps around to the front and meets the cartilage in the front there. And also there's 35 muscles that attach to the pelvis area, but these can be broken down into hip external rotators, hip internal rotators, flexors, extensors, abductors, adductors. So when we start breaking things down into more specific groups, there's really only 5 or 6 groups of muscles that surround the pelvis. What are some requirements for a healthy SI joint? Good posture, and that has been kind of debated in the literature now. But really we know that by going into a significantly increased lumbar lordosis, it's going to change the position of the SI joint. Whether or not that can long-term affect the health of the SI joint, we don't really know. We can't confidently say that. Some things that do provide stability around the SI would be proper force closure, which we'll talk about later. Strong posterior chain and core muscles, so more of the forearm closure, force and forearm closure there together. Good hip mobility, and then good hip stability, especially unilaterally. And we'll give an example with a lunge later on too, that shows why you need to have good hip stability. With sacroiliac joint anatomy, well, they are articular. The articular surface on either side is kind of this ear-shaped structure, but it varies from individual to individual. And that's what makes studying the SI joints so hard, is there's so much individual variability. It begins as a relatively smooth surface, indicating that there'd be more movement early on in life, but gradually develops these ridges, which eventually ankylose and kind of fuse together. So much more limited movement because of these ridges later on. When we discuss the ligaments surrounding the SI joint, you have your strong interosseous ligament, and that is located between the lateral sacral crest and the iliac tuberosity. So you can see that ligament that runs just to the medial border of your sacrospinous ligament, and also your long posterior SI ligament. So this is the one that is the primary barrier to palpation of the joint. If you would try to palpate in there, the interosseous ligament is thick and dense, and it bars your exact palpation of the joint. Also, the long dorsal ligament it attaches from the sacral crest around S3 and 4, and PSIS, and is posterior to the interosseous ligament and inferior to the PSIS. So as you can see, that long posterior or dorsal ligament here is just inferior to the PSIS, and it's right around or even right over parts of the interosseous ligament. This prevents counter-nutation of the sacrum. When we say that term, what that means is if this is in the front and this is in the back, here is nutation, here is counter-nutation. So that long dorsal ligament, it prevents that counter-nutation from occurring. Next, we have our sacrotuberous and sacrospinous ligaments. The sacrotuberous ligament, as you can see at the very bottom of the picture here, it connects the sacrum to the ischial tuberosity, and it also is an extension of the biceps femoris. So that tendon then goes down and becomes lateral, or it transitions from ligament through fascia into the lateral hamstring. This ligament prevents nutation of the sacrum. So you can imagine if the sacrum is trying to nutate forward, but you have this thick ligament here that's restricting that movement, that's the function of the sacrotuberous. It is important to consider the significance of these ligaments in both SI dysfunction and low back pain. So if someone, potentially if they fall on their ischial tuberosity, they may develop some laxity in their sacrotuberous ligament, and that could lead to some relative instability either at the SI joint or through the low back. Along with the sacrotuberous, you also have your sacrospinous ligament, which you can see right here. It's over on the right side, bottom right side of you can see the arrow for it, and then trace that up there, and that also prevents nutation. So both the sacrotuberous and sacrospinous prevent nutation of the sacrum. Finally, the iliolumbar ligament attaches from the L4-5 transverse processes and SI ligaments along the lateral crest of the ilium. This helps maintain stability of the lumbosacral junction in both the coronal and sagittal planes. Sometimes increased stability necessary due to transmission of forces from the lower extremity. And what that means is that as someone's walking, squatting, doing a lunge, you're going to have so much force going across the pelvis that there needs to be some ligamentous support that goes from the lumbar spine to the pelvis to provide some added stability. Finally, we talked about the thoracolumbar fascia earlier. It's 3 layers of fascia that separate the muscles, and it's also important for providing stability and helping transfer load. So if you would think about, as someone even draws in their abdominal muscles, that directly links in with the thoracolumbar fascia. Now, it is fascia, so it's highly innervated tissue, and it needs to have good mobility, but it also needs to develop tension. So the fascia has to have that balance of being stiff and strong, but also being elastic and mobile. We mentioned the different requirements for a healthy SI joint earlier, and here is that form closure and force closure. Form closure is stability achieved through the close-fitting joint surfaces. So this is more, form closure is more bony stability. So forces are going to be stable through compression in that wedge shape of the joint. The flat joint surface is at risk of shear, and the ligaments, although they're strong, are going to be vulnerable to creep if you put yourself in these prolonged postures. So if you think of someone who is sitting down like I am for this lecture right now for more than 15 minutes or so, if I'm sitting in a very flexed low back posture, so kind of slouched down, the SI ligaments can get put on a relative stress, or they're going to go have relative creep in the ligaments, which could then, in theory, cause some decreased stability around the SI joint. So that's why naturally, if you watch me every 5 or 15 minutes, I'm just naturally moving around because my body's saying, hey, don't let that creep develop because you need to have that natural form closure. Force closure is then going to be the muscular stability. So form is bony, and then force is muscular. I think that makes sense because muscles, they can produce force, so they help give this extra stability and compression through their muscle activation. Some local forms of force closure are going to be your pelvic floor, your diaphragm, your TA, your multifidi, so really those core muscles that we think about, because those help increase intra-abdominal pressure, they help create joint stiffness, they create tension in the thoracodorsal fascia. And then also on a more global level, we have these slings that run throughout the body that also help create force closure at the SI joint. When we talk about those slings, we won't go through all of these, but there are 4 slings for pelvic stability. The most common one is going to be the posterior oblique sling, and that runs from your lats down across through the thoracodorsal fascia and then into the glute max on the other side. So you could create added stability at the SI joint from that connection from the lats down through the gluteus maximus on the opposite side. That's why someone who's having SI type symptoms would benefit from the bird dog exercise, for example, because that exercise, it engages the lat on one side and then the opposite glute, creating natural force closure across the SI joint. As you can see with these other slings, they encompass the oblique muscles, the adductors, but really all the different muscle groups around the SI joint. And clinically, I would say the importance of these is to really look for your impairments. So if someone has decreased hip mobility, it could be because of either too much or too little tension across some of these slings. And then also, so treat the impairments. And then as you are working on adding more, let's say, force closure around the SI joint, you just have to be modulating their pain all the time. So if someone is having pain with compression, but they also need stability, you have to address the pain and irritability first, and then gradually introduce taking up tension through these slings. Biomechanics of the SI joint are irregular, they're atypical, the research is very inconsistent. But what you can see is there's motion in 2 different planes. You have your rotational axis, which is 1 to 8 degrees of rotation, and then translation. So that's going to be 0 to 8 degrees of translation. Very minimal movement, but what I look for is symmetrical movement side to side. And even that, the theory of should it be symmetrical or not, is now being questioned across the PT research. It is important to know that no muscle acts to specifically move the sacrum. And again, that's why, since there's really no direct muscular control around there, that we must look at where the muscles run. So potentially, let's say if someone's having SI type symptoms, it could be coming from the hip flexors, which cross the SI joint region, but run from the low back down to the hip. So since it's really hard to quantify SI joint biomechanics by itself, let's look at this as a more general scale. So let's look across the whole lumbo-pelvic rhythm. When someone bends forward, what you should see is as they're going into the movement, they're going to have a combination of both lumbar and pelvic movement. So in this picture here, you see the person as they start to bend forward, the lumbar spine is flexing, 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 and then you get some anterior rotation through your pelvis, through both the ilium and the sacrum, which allows you to get all the way down forward. It's a combination. These things must work together. You'll see some people who don't posteriorly shift their hips when they go to bend forward. And because they're not, when we talk about lumbo-pelvic, so the low back, pelvis, and hips, those three things need to be working in conjunction. And typically, if someone has pain while bending forward, there's a limitation in that coordinated movement. What we're going to talk about next is the iliosacral motion versus sacroilial motion. And this is a confusing topic, so if you don't understand it on the first go around, please listen again, and please try to, I would recommend reading the Donald Newman kinesiology textbook. It helps break down these concepts. Again, I'm not sure how clinically important all of this stuff is, but understanding the mechanics really does help understand how the muscles activate and what happens in the body as someone's doing a particular movement. If we look at the iliosacral movements, this is going to be movement of the ilium relative to a fixed sacrum. So if here's my sacrum and here's my left ilium, it is going to be movement. If the sacrum is not moving, it is going to be this sort of motion. And so you could think about that as, if I go into hip flexion, my ilium is naturally going to have to tilt forward. Hip extension, it's going to have to tip backwards. So the sacrum is not moving, it's all what's happening here. And it's easier to think about these if the ilium were just connected to the femurs. With iliosacral motion, you have your anterior pelvic tilt and posterior pelvic tilt. Anterior pelvic tilt is going to be associated with extension of the lumbar spine, but then also hip flexion. So someone tilts forward, you can see more lordosis, but then also the hips are flexing forward. With a posterior tilt, it's going to be associated with lumbar flexion, as you can see in the picture on the right. And then that's a relatively extended position of the hip. The important functional correlation to this is someone doing a lunge. So if you look at this picture, you say, what is occurring at the pelvis on the right side here? So the left leg is forward, right leg is back. Well, we know that they're going into hip extension. And so on the right side, if they are going into hip extension, the ilium rotates relatively which way to the sacrum? That is going to be anterior to the sacrum. And then also this movement closes or relatively compresses the SI joint on the right side. I need to clarify something here though, because if we look at this side, if someone is going into an anterior pelvic tilt, that's associated with hip flexion, but they're different requirements of the movement, and that's why they look differently here. So this person on the right side, they're going into hip extension, but that hip extension is causing a relative anterior rotation of the ilium. What's occurring on the left side? Well, the left hip is moving into flexion, but as that hip goes forward, they're posteriorly rotating the ilium on that side too. And then this movement is going to open up the SI joint. So the anterior pelvic tilt is associated with more of a closing down of the pelvis, and then the posterior pelvic tilt is more associated with opening the SI joint. Those concepts are important because you'll see people who, when they come in with low back pain, they might really be favoring lumbar flexion or relatively a posterior tilt to their SI joint, because that's going to open up the movement. And then you might also see people who are very anteriorly tilted. Maybe that person is seeking stability, so they anteriorly tilt, which closes down the SI joint, and that gives them more stability. So how they present can give you an indication of what movement they need and what movement they're lacking. And then finally, we're going to talk about sacroiliac motion. And then this is going to be movement of the sacrum relative to a fixed ilium. So here's your sacrum, ilium is fixed. So now it's the sacrum moving as a continuation of L6. So you can imagine if I go into lumbar extension, my sacrum has to nutate at the same time. And those motions working together are going to allow for this natural nutation and counter nutation of the pelvis. When someone goes into sacral nutation, there is going to be relative hip internal rotation the SI joint becomes more closed off, so everything gets stiffer with nutation. And then there's a relative posterior motion of the ilium. What I mean by that is if the ilium's staying stable and there's nutation here, well, this thing is it hasn't moved, so it's relatively posterior now. And that's a tough concept to comprehend. Finally, with sacral extension or counter nutation, we're going to have relative hip external rotation. If you would think about that in relation to the previous slide, that person who is seeking more of an open SI joint position, where they go into a posterior rotation to their sacroiliac complex, well, that's going to be associated with the hips wanting to fall out, and again, more of an open pattern. With sacral counter nutation, the SI joint is distracted, and then now we have relative anterior motion at the ilia. A great way to break down this movement would be to look at, this is a downward dog, which is a yoga pose, but really you could think about it as a hamstring stretch in what's happening here. When the knees are straight, the sacrum and ilium are pulled opposite, which can put extra stress across the SI ligaments. So you have as someone bends forward, the ilium will move in one direction, but the sacrum is going to follow the spine. And so there's going to be a relative tractioning across the SI ligaments. With the legs straight, the hamstrings are going to restrain that anterior pelvic tilt. So because tension across the hamstrings, if this is the backside of the legs, those are going to be pulled tight, relatively limiting how much movement can occur across the pelvis into an anterior pelvic tilt. With that same movement with the knees bent, the sacrum and ilium are free to move in the same direction, and that's going to place less stress across the SI joints. When someone comes in with low back or SI type symptoms, by simply bending their knees when they go into forward flexion, it decreases so much stress across this region, because it allows for more freedom of movement between those surfaces. And as you can see there, with the knees bent, the pelvis can follow the motion of the sacrum. Therefore, there's going to be less stress placed across the SI ligaments. Now, one is not better than the other here, knee straight or knees bent. It's going to demonstrate potentially someone's irritability levels. If you are confused with SI movement, SI joint mechanics, you are not alone, because even the current concepts of the lumbosacral region, which is current concepts with the orthopedic OCS specialty study guides, it says there's no consensus on movement, and there's also very little consensus on treatment. So please review that, but also understand that it takes weeks or months of repetition to really understand what's happening here. That is the lumbar spine anatomy, biomechanics, and movement. If you have any questions, please feel free to reach out to us at the Student Physical Therapist. Thank you.